Hello, good evening. Welcome to tonight's webinar organized by the Spinal CSF League Canada. My name is Yasmin Hoydongs. I'm one of the physicians at the University Health Network in Toronto. And it's my pleasure to introduce Dr. Andrew Callan tonight. Tonight's webinar is, of course, about spontaneous intracranial hypotension. As you know, it's a debilitating neurological condition caused by leakage of cerebrospinal fluid, either through a dural defect, a ruptured nerve root sleeve, or directly into a paraspinal vein. Although our understanding of SIH has increased in recent years and newer imaging techniques have improved to localize the site of these leaks, difficulties in diagnosis and finding these leaks are remaining. This webinar tonight will delve into advanced myelographic imaging techniques, which can be used to localize CSF leaks and CVF. Please let me introduce Dr. Andrew Callan, who is an assistant professor of neuroradiology at the University of Colorado School of Medicine, where he is also the director of the CSF Leak program. Dr. Callan specializes in diagnosing and treating spinal CSF leaks and leads a collaborative team of radiologists, neurologists, and neurosurgeons to provide cutting-edge testing and treatment for SIH at the University of Colorado School of Medicine. Dr. Callan is also a member of the Medical Advisory Board of the American Spinal CSF League Foundation. The title of his talk today is Diagnosis and Treatment of Spinal CSF Leak and CSF Venous Fistula, an Algorithmic Multimodality Approach. Before I give the microphone to him, I would just like to state that during this presentation, please advise that questions can be asked at any time in the Q&A chat box. And we'll do our very best to answer all of them in the 15 minutes time slot that we've provided at the end of this talk. Thank you, Dr. Callan.
Thank you very much. And I'd like to thank the Spinal CSF League Canada for the invitation to speak today. Thank you for the introduction. It's my pleasure and honor to be here today to talk about my favorite topic, which is CSF leaks. And I'm going to be talking both about spontaneous intracranial hypotension and iatrogenic intracranial hypotension. So let's dive right in. I am on the Medical Advisory Board of the Spinal CSF League Foundation. I'm also do consultant work for Eli Lilly Pharmaceuticals. That is not relevant for any of this content today. I think that there is a lot of parallels between a disease that we may not find related at all to spontaneous intracranial hypotension, which is multiple sclerosis. If you look at the history of multiple sclerosis, a disease which we consider common and routinely diagnosed today, you may find some parallels and interesting similarities to intracranial hypotension. In the 18th and 19th century, MS was considered a rare disease. And these patients, commonly young middle-aged women, were diagnosed with hysterical paralysis, told there was nothing wrong with them, that it was all sort of in their head. But it wasn't until there was new diagnostic tools that we were able to accurately diagnose these patients with this disease, and that led to a massive increase in diagnoses. And in the present day, this is one of the most commonly diagnosed diseases that we see in radiology. It's, we're reading these MS follow-ups all the time. We take it for granted how easy it is to make this diagnosis. Same can be said for many of our patients who have been living in the transitionary period of the revolutionary diagnostic test that we have for SIH. This is one of my patients who in 2016 had a routine CT myelogram, which showed no evidence of a CSF leak, and was ascribed these 6 diagnoses to account for his symptoms. None of those were correct. He had a CSF venous fistula, but we just didn't have the appropriate test to find that. Here is a dynamic decubitus CTM showing a CSF venous fistula at that very level. Patients can present with an orthostatic headache, perhaps the most characteristic finding or clinical manifestation of this disease. And here's an example of a young boy who had a large CSF leak that we treated laterally here. But also the clinical manifestations can be much more diverse and complicated. This person didn't really have an orthostatic headache, had more of a periorbital headache and personality change associated with their CSF venous fistula. And this patient had coma and paralysis and eventually died from her CSF venous fistula. So the clinical manifestations can be incredibly diverse and challenging. And so it's not just an orthostatic headache. There can be a wide number of symptoms which can make the clinical diagnosis incredibly challenging. But in general, we think that most patients have orthostatic symptoms, meaning that over 90% of patients are worse when they are upright and they are better when they are flat. That orthostatic nature also is reflected in the sort of characteristic brain findings that we see. So according to the Monroe-Kelly doctrine, where there's a fixed volume within the craniospinal compartment comprised of brain, CSF, and blood, as CSF is deliquerated from the craniospinal compartment through a CSF leak or venous fistula, there's sagging and traction in the meninges, venous engorgement, and structural distortion, which is then reflected in what we see on the MRI of the brain, with these sort of characteristic imaging findings of dural enhancement, diffuse pachymeningeal enhancement, brain sag, hemosiderosis at times, subdural collections, venous engorgement, and pituitary engorgement. Let's go through these in a little bit more detail. So the brain sag checklist. On the screen left, we have a normal MRI of the brain. On screen right, we have an abnormal one. And what specifically is abnormal? Well, number one, if we draw a line that approximates the tentorial incisura, and we look at the relationship of the aqueduct to that line, the aqueduct should be at or above that line, but not below it, as in the case of a sagging brain. The suprasellar distance shown in the yellow here will be narrowed as the pituitary gland engorges and as the optic chiasm descends. The floor of the third ventricle will also can be downsloping, as opposed to upsloping on the normal brain on the left. The mammillopontine distance, shown in red, will become narrowed, as will the prepontine distance. And then, of course, the cerebellar tonsils can descend below the foramen magnum. However, this cerebellar tonsillar ectopia is commonly mistaken as a Chiari-1 malformation. So we have two MRI brains here. On screen left is a Chiari-1 malformation with cerebellar tonsillar ectopia. On screen right, there's also cerebellar tonsillar ectopia, but this patient has SIH. Let's look at those same features between the two brains. We see that in purple, the suprasellar distance is narrowed in the patient with SIH. The floor of the third ventricle is downsloping, not upsloping. The prepontine and mammillopontine distances are narrowed. And then, of course, the cerebellar tonsils are descended below the foramen magnum. A Chiari-1 malformation is one where the bony posterior fossa is too small to accommodate the contents therein, therefore squeezing out the cerebellar tonsils, where, of course, in SIH, the CSF loss results in sagging of the brain down through the foramen magnum. This is very important because we see too many patients who've been misdiagnosed as having a Chiari malformation and undergo a decompression potentially for suboccipital decompression when that is totally unindicated and inappropriate. So this patient came to us complaining of persistent orthostatic headache after a Chiari decompression. We unfortunately didn't have her preoperative imaging. We could see right away that there's features of SIH here. There's sagging of the posterior fossa contents. There's even subdural fluid collections here. So we said there's no way that you may have had a Chiari malformation at one point, but you certainly have SIH now. She indeed had a CSF venous fistula on the right at T910. We performed occlusion of that fistula using percutaneous fibrin, and lo and behold, her MRI brain changes reversed, as did her symptoms. Diffuse dural enhancement, sort of the hallmark radiographic feature of intracranial hypotension, also can be commonly mistaken for other entities. And what I want to get across is that diffuse, smooth circumferential dural enhancement is almost always CSF hypovolemia, either from a lumbar puncture or CSF removal intentionally or unintentional spontaneous loss. This patient was referred to us, actually to our neurosurgical colleagues, for a dural biopsy because they were concerned he had pachymeningitis. We took one look at this and said, no, this is diffuse, smooth, circumferential pachymeningeal enhancement. This is SIH. He had a CSF venous fistula, and of course, after ligation, surgical ligation, in this case, that pachymeningeal thickening resolved. Pituitary engorgement, what we're looking for is this upwardly convex margin of the pituitary gland, which also results in a narrowed suprasellar distance. This can be very challenging because the pituitary gland is different in morphology depending on the patient's age. So a young patient will have a much larger pituitary gland than a much older patient, so you have to interpret those findings with caution in the context of the patient's age. Venous engorgement is a very important finding, and perhaps sometimes the only finding that you'll see. It's good to look at the sagittal image, a parasagittal image, often at the level of the orbits, and look at the upward margin of the transverse sinus to see if we have a flat or concave upward margin or a convex upward margin, which would be abnormal in the case of that venous engorgement. And we think that as that venous engorgement occurs, then the results is increased venous permeability and then leakage of fluid or CSF or blood into that subdural space, resulting in subdural fluid collections. Patients often get, they get drains put in, a septs, what have you, to drain these collections, and they will just reaccumulate if the underlying CSF leak is not treated. We can quantify these findings in the Burn score. The Burn score looks at these findings which we just discussed and ascribes particular measurements to the narrowing of the suprasellar, prepontine, and mammalopontine distances to assign a probability of finding a CSF leak on subsequent myelography. It was first described in the context of conventional myelography, looking for dural tears or meningeal diverticula, and then both us and others have validated these findings for CSF venous fistula on dynamic CTM and digital subtraction myelography. We find it so important to use this Burn score for reasons which will show in a little bit, that we've implemented standardized reporting here at the University of Colorado for all MRI brains which get sent to us for concern for SIH. We found that when our readers, our neuroradiologists, use a template asking them to report the Burn score, they have decreased discordance versus an expert blinded reader. They call less false negatives for SIH and no false positives, and that radiologists just aren't that good at sort of qualitatively assessing mild narrowing of these intervals. And that's what they tend to miss the most. Superficial siderosis isn't encoded in the Burn score, but is very important to recognize. We think that as a dural defect occurs, CSF accumulates in the epidural space, resulting in repeated microtrauma to the epidural venous plexus, and then hemosiderin circulates into the subarachnoid space and deposits on the PL surfaces. This is very important because it can result in its own clinical syndrome, which is largely irreversible, consisting of sensorineural hearing loss, ataxia, and once it's present, surgery is usually required. And this was shown by a very nice large series out of Cedars-Sinai just this past year in Annals of Neurology. There are many atypical presentations of SIH. I won't describe them all here, but here's one that's important to recognize. This patient presented to our emergency department with a headache, was told that the CT is normal, was sent home, came back 5 days later, and a repeat non-contrast head CT showed this new hyperdensity throughout the dural venous sinuses, and the patient had developed diffuse dural venous sinus thrombosis. MRI of the spine showed a longitudinal epidural fluid collection, as shown here, and we diagnosed this patient with a ventral dural defect with prone dynamic CT myelography. So remember that dural venous sinus thrombosis can be a manifestation of SIH. The leading theory in this regard is that venous stasis from engorgement results in a sort of, that stasis results in coagulability and development of thrombosis. Now that we've talked about the Burn score and we talked about what findings can be present on an MRI of the brain, it's really important to remember that not all MRI brains are going to be grossly positive. One study that gets cited frequently in the context of spontaneous intracranial hypertension is this meta-analysis from JAMA Neurology, where they reported that brain MRI findings were normal in approximately 19% of MRI brains in patients with proven spinal CSF leaks. It's important to remember, as one of my favorite mentors said, radiology is not a CBC, a complete blood count. Okay, it's not a machine that spits out a number that says 0 or 1, whether a brain is positive or negative. There's a person behind that interpreting that study, and that person may have a different interpretation of what normal means. I would like to break down normal and argue that normal can mean 3 things. There can be true negatives, MRI brains that are truly normal no matter how you slice it, false negatives, which are misinterpreted by the radiologist as negative when in fact they are positive, and there's this phenomenon of normalization over time. In the context of a true negative MRI brain, here's one. So this person has no pachymeningeal enhancement, no subdural fluid collections, very minimal narrowing of the prepontine cistern, but really no narrowing elsewhere, has a massive longitudinal epidural fluid collection that would have been totally disregarded if the brain had been looked at in isolation, out of the context of the patient's symptoms and without looking at the spine. We localized this patient's defect to a lateral dural defect in the lower thoracic spine. This was repaired surgically with resolution of that fluid collection. There can be false negatives as well. And this is where the Burn score comes in handy, because this MRI brain was read as no evidence of SIH, negative. But if we apply the Burn score, we see that there is mild narrowing of the suprasellar, mammalopontine, and prepontine distances. There's no dural thickening, subdural collection, or venous engorgement. And so really this is a Burn score of 4, meaning there's an intermediate probability that we'll find a leak or fistula on this person's myelogram. And indeed, she did have a myelogram. She did have a CSF venous fistula on the left at T7-8, found on our dynamic CTM. I want to remind you here, just take a second to remind us all that the Burn score is the likelihood of finding a leak on myelography. it is reflective of the inherent sensitivity of that test. It is not the likelihood the patient has a leak. It is not a reflection of the patient's clinical severity. It is not the likelihood the patient will feel better if we patch them. It is simply a probabilistic score that whether or not our test will find a treatable, localizable finding. Finally, there's this concept of normalization over time. This patient presented in 2018 with an orthostatic headache, had classic imaging findings of intracranial hypotension with subdural fluid collections here and sagging of the brainstem, had a ventral epidural fluid collection in the spine, had a non-targeted epidural blood patch, but had incomplete resolution of symptoms in 2023, returned, had a normal brain MRI. In isolation, this would have been said, okay, no evidence of SIH, let's move on. In her spine, the fluid collection persisted. And indeed, this was repaired surgically with a massive reduction in her symptoms post-operatively. So remember to interpret the burn score in the context of the probability of finding a leak, but also that the longer that a patient lives with a leak, the more likely that their brain MRI will normalize. Touching on that brain MRI severity not being equivalent to symptom severity, a nice paper just recently came out of Duke looking at 57 patients with proven SIH with pre-treatment HIT6, that's a validated headache score measure, and MRI brain. They showed a very low correlation between headache severity and burn score. And so really, this burn score, again, is not how much the patient is suffering. It is simply how likely it is that we are going to find a leak. What about opening pressure? I mean, encoded in the name, intracranial hypotension, is this assumption that these patients are living in low pressure. And in the ICHD3 criteria, it says specifically, this is a headache caused by low CSF pressure. And to make the diagnosis, you need either a measured low pressure or evidence of leakage on imaging. However, there's been study after study, including some of our own work, that has shown that most people living with this disease do not have low pressure at all. This is not a condition of low pressure, and we have advocated, as have others, that this should be removed from the ICHD3 criteria to make the diagnosis. And we would especially not want practitioners to just perform a lumbar puncture for diagnosis of this disease in isolation, subjecting the patient to a potential post-dural puncture headache and performing a test which is not sensitive to find the disease. A normal opening pressure does not rule out a leak. Do not send your patient away telling them they don't have a leak if the pressure is not low. Let's talk about post-dural puncture headache. This is a very important sister diagnosis to spontaneous intracranial hypotension, and frankly, one that I treat in at least half of my patients that we see in clinic here. There's a common statement made in post-dural puncture headache. It's always negative, so don't even bother looking, and we're never going to see anything. I'd like to make the argument that that's not true, that the imaging is usually negative, but there are findings that we can make in these patients, and it's important to pick up on them. Let's talk about what they are. So in the acute setting, you can see epidural fluid collections. And in the chronic setting, we can see epidural edema and we can see dural irregularities. So let's look at an obvious case. So here's a 22-year-old woman who's 2 days postpartum after a wet tap, as the anesthesiologists call it. She had a labor epidural. There was concern of a dural puncture. She had a severe orthostatic headache. Her brain MRI shows classic findings of intracranial hypotension. And indeed, she has a spinal epidural fluid collection. No questions here. But look posteriorly as well. There's insinuation of edema in that dorsal epidural fat, sort of a finding that might get overlooked otherwise. And this sort of has this undulating contour in that lumbar epidural space. And we'll come back to that in a second. So, when we perform myelograms, we see extradural contrast all the time at the site of the puncture. Here's a CT myelogram on screen left showing epidural contrast dorsally and laterally. And here's an MRI myelogram after administration of intrathecal gadolinium showing extravasation of contrast at our puncture site. Not fun to see, especially when we're in the business of treating leaks, to see that there's CSF leaving the intradural compartment. It turns out that seeing that extradural fluid on MRI post-puncture does not correlate well with giving a patient a post-dural puncture headache. Sort of a sigh of relief for all of us who see this on myelography. This nice study looked at patients with and without that findings of extradural contrast after a lumbar puncture, and there really was no difference in those who did or did not suffer from a post-dural puncture headache after their puncture. We can see this not just with contrast, but you can just see it with saline. So in my patients who are averse to having intrathecal gadolinium for MR myelography, I will perform pressure-augmented saline myelography, where I'll perform MRI pre and post infusion with saline to look for a slow leak. You can see in this patient right here in the pre-augmented myelogram, nothing really remarkable here in the extradural compartment. Post-saline, though, you see both at the puncture site there in the red arrow, as well as that undulating dorsal epidural edema. This is sort of a perfect counterfactual showing evidence of these things right after our puncture that they can happen. And if they are happening outside of the context of immediately in the post-myelographic setting, it's something to pay attention to. It turns out this has a sort of a cute name, the dinosaur tail sign, which is described in this paper in 2017. This group looked to see whether people who had this finding were more likely to be suffering from post-dural puncture headache or SIH. They found that this finding is quite sensitive but not specific for the presence of SIH or a post-dural puncture headache. And in people who did not have SIH or post-dural puncture headache, really none of them, very few of them had. The only two of the 35 in that cohort had this finding at all. And of those two, that edema was confined to one interspace. So if you see this edema contiguous in more than one interspace, it's worth mentioning in your radiology report. It's possible this is a positive sign in a patient with post-dural puncture headache, and that their imaging is not just negative, right? So let's look at an example of this. This is a woman who was 1 day postpartum, had a ventral epidural fluid collection and a dorsal epidural fluid collection, and had this lumbar epidural edema. Had a bedside lumbar blood patch with anesthesia, 70% improvement in their headache, but came to see me 5 months later with an MRI that was read as negative. But I'd argue that it's not negative. We still have this lumbar epidural edema, which was present in the acute setting and is still there in the chronic setting. We patched her repeatedly and she had improvement of her symptoms after this, but it's just important to remember that the imaging is not always negative in these patients. Let's go outside of just the context of epidural edema and look at dural irregularities as well. This is a 42-year-old woman who suffered from disabling orthostatic headache for 6 years. Her brain MRI showed no findings of SIH. She had numerous enlarged meningeal diverticula, which led to multiple institutional workup with DSMs, dynamic CTMs, looking for CSF venous fistula or ruptured meningeal diverticulum, all of which was negative. But the first MRI she had before any of those DSMs or CTMs showed this very small outpouching at the L3-4 level here along the dorsal lumbar dura. We talked to her more, and she did have a labor epidural 18 years prior to presentation. And after that, she had a brief self-limiting headache and then no headache for 12 years after that, developing her current presentation. I went in and tried to patch this with fibrin glue. And I did a little test injection with contrast here right at that level. There's my needle. There's our epidural spread of contrast. And we see this very interesting finding of contrast intravasating into the subarachnoid space and then layering in the subarachnoid space along the ventral canal here. She had very, very profound symptomatic improvement that only lasted 2 to 3 weeks after that fibrin patch. So we sent her to surgery. Intraoperatively here, this is done through a minimally invasive approach through a tubular retractor. The surgeon saw this membrane covering this area. Once that membrane was dissected away, this bleb was uncovered. And at the base of that bleb, there was weeping CSF at the base of that bleb. This was reduced. And we think how could this be? How could this be leading to symptoms, and why won't a patch fix this? Well, we can imagine if there's a needle violation of the dura and subjacent arachnoid layer, this could lead to a dural defect, and then sort of an arachnoid plug, or with a sort of ball valve mechanism with leakage from the base. And you try to patch this patient, you may get partial coverage of this defect, but perhaps not complete coverage of the defect. And that area can continue to leak, but with operative repair and primary closure, she has had profound and durable symptom resolution. So please scrutinize the dural contour on your MRIs for any of these sort of blebs, which can be caused by instrumentation generally, and may be a cause of chronic post-dural puncture headache in our patients. We have to rethink again the ICHD3 definition of post-dural puncture headache, which states that it has to be within 5 days of a lumbar puncture, but it's not only within 5 days of a lumbar puncture. So many of our patients are living with this condition chronically. It's an incredibly debilitating diagnosis and falls in the family of intracranial hypotension. Please remember post-dural puncture headache even in the chronic period, and remember to take a very extensive history of any needle in your patient's back. So you suspect a leak based on clinical features and or your brain MRI. Where's the leak going to be? So many of my patients ask me this question. Sometimes I have clear drainage from my nose. Could I be leaking from a skull-base leak? Could that be where my CSF leak is? We think that for most of the time, the answer is no. And the reason for that is that in the upright position, there's a pressure gradient in the craniospinal compartment where the pressure is the highest at the lowest part of that fluid column. It becomes progressively less high up to about 0 at this place called the 0 pressure point near the skull base. And then in the upright position in the intracranial compartment, the pressure is actually slightly negative with respect to atmosphere. So in order for there to be spontaneous leakage, which is worse in the upright position, it really has to be below that 0 pressure point. Now, there's exceptions to this rule. There's case reports published of some exceptions of leakage in the skull base, but for the vast majority of patients, this condition will be caused by a leak in the spine. So when we want to evaluate the spine, we want to perform spinal MRI. And really, we think that a 3D T2 fat-saturated MRI, also called non-contrast myelography, is the best study to do this. And I'll make that argument in three main ways. Number one, decreased CSF flow artifact. Number two, the presence of axial T2 fat-saturated sequences, which are not acquired on routine spine MRI. And then finally, heavy T2 weighting. So on our conventional fast spin echo T2 2D sequences, we commonly see CSF flow artifact. Radiologists read through this all the time. We probably don't even notice it as we're reading through the spine. But in our 3D sequences, we can get rid of that. And other than it just being sort of a nice thing to not have to look at, this actually makes a big difference when you're looking for the presence of an epidural fluid collection. So on the left here, there's an image of a T2 stir image of a patient with a ventral epidural fluid collection. The 3D T2 fat-saturated image nicely recapitulates this finding. But this patient has a very similar sort of line in the ventral and dorsal thecal sac, but the 3D T2 fat-saturated image shows that this is just flow artifact. So I very much would advocate that this sequence can help us localize and characterize the presence of epidural fluid collections. Again, as I mentioned, a conventional MRI of the spine does not have axial fat-saturated sequences. So if we're scrutinizing these lateral epidural space in the neural foramina, we have no idea if what we're looking at is fat or fluid. But with the presence of a 3D T2 fat-saturated sequence, we can see clearly that there's epidural fluid here, which correlates very nicely to the decubitus dynamic CTM we have on this patient, allowing us to localize that defect and that leak in a non-invasive way. There are pitfalls when you look at the MRI of the spine when you're trying to characterize a leak. Here's one pitfall, an engorged epidural venous plexus on this T2 non-fat saturated image. The red is showing us that there is indeed a ventral epidural fluid collection, but the blue arrow is showing us that there's dorsal epidural venous engorgement. Remember, fat is bright on T2 non-fat saturated images. Important to remember that as well. There's also this concept of a false localizing sign. The epidural space is a potential space confined by the dura and then the spinal canal posteriorly. At the C2 level posteriorly, this space opens up. And if all four of these patients have spinal epidural fluid collections, and that fluid is tracking up the epidural space and then leaking out posteriorly at C2, their leak is not at C2. This is just where the fluid is tracking out. I can't tell you how many times they get paged and they say, oh, there's a patient who needs to be transferred here immediately for an emergent blood patch at the C2 level. And I just know before I even open the image that this is almost certainly a false localizing sign. And they do have a leak, but it's probably elsewhere. Now, this space communicates, and there's lots of ways to show it. So this patient had a longitudinal epidural fluid collection. This patient had a conventional myelogram where the contrast was inadvertently injected into the epidural space. And you can see beautifully that contrast is tracking all the way through the epidural space and then pouring out right at that C2 level. This patient had a Chiari decompression and then developed symptoms and imaging findings of intracranial hypotension. And we see here that when we first looked at our imaging in August 2021, there was no epidural fluid collection. There was, however, fluid along the cranioplasty defect. In about a year later, that fluid really increased at this level. And there was also beginning to be a spinal epidural fluid collection. I said, okay, well, certainly she has a spinal dural defect. However, upon repeated examinations, we could never find this spinal dural defect. We said, well, is it possible that she's leaking through the cranioplasty mesh and that fluid is communicating into the epidural space and giving us sort of a reverse false localizing sign? And indeed, that was the case. There was a defect in her cranioplasty mesh. The fluid was pouring out here, tracking back to that same anatomic compartment and giving her a false localizing spinal epidural fluid collection. This mesh was repaired and she had resolution of these symptoms. Here's our spinal CSF leak types, okay? Here's my beautiful, very anatomically correct cartoon drawing of a spine. And we can think about these in three general categories. The ruptured meningeal diverticulum, the dural defect. Both of these have epidural fluid collections. And then, of course, the CSF venous fistula, where CSF is lost directly into an adjacent paraspinal vein. And the next thing we have to do and think about is what sort of invasive tests are we going to do to characterize the presence of these leaks or fistulas? A conventional CT myelogram is a study where the radiologist injects X-ray dye into the spinal fluid space, often under fluoroscopy, waits a long time as that contrast diffuses throughout the spinal subarachnoid space. Maybe the patient rolls around on the table to get that to diffuse everywhere. And then we're able to delineate the subarachnoid space very nicely and the epidural space. And if there's leakage, we will see that there is dye leaking into the epidural space. We have no idea where it's coming from. in a conventional CT myelogram. Is there a role for this study anymore in SIH? Probably not in the way that I just described it. So with these 3D T2 fat saturated sequences, we can characterize the presence of an epidural fluid collection without subjecting our patient to radiation and a lumbar puncture. And a couple of nice studies have demonstrated the non-inferiority of this sequence to a conventional CT myelogram. Digital subtraction myelography, whereby contrast is injected in real time with the patient on the fluoroscopy table, and then digital subtraction technique is employed, is very good at showing us exactly where these leaks might be. But there are downsides to this technique as well. There's a limited field of view. Wherever you point the the fluoroscopy machine, that is where you will get your images, and you'll be missing the part that you are not looking at. You'll have superimposition artifacts, particularly at the craniocervical junction and where the shoulders are. Very challenging to see. And if there's any motion at all, that can cause problems as well. So patients will often have to receive general endotracheal anesthesia to suspend breath holding. Whereas conventional CT myelography, while it has very poor temporal resolution, as I just sort of described, it has a very large field of view. You can image the entire spine at once, and you can assess any sort of contributory surrounding anatomy. So if you combine the benefits of both these exams, you can get what we call dynamic CT myelography. If we inject on the CT table and scan immediately, acquiring multiple phases at once, we get very good temporal resolution. If we use sub-millimeter slices, we get very good spatial resolution. And then we get the benefits of CT with the additional benefit of being able to treat in the same setting with the patient right there on the CT table. So this is the study of choice at our institution. And depending on where you go, they may choose a dynamic CTM or DSM, depending on the sort of resources available. A very nice study just came out within the last several days, comparing DSM versus CTM in lateral decubitus positioning for the discovery of CSF venous fistulas, and found that CTM was superior in their study for finding those venous fistulas, further lending to the support for the use of this study. But there's problems with doing CT. In fluoroscopy, you can inject your contrast and then use the tilt table to move contrast down the spine and control the spinal bolus, but CT doesn't have a tilt table. And if you're trying to position the patient on the CT gantry, you may use a hover mat, sort of an inflatable mattress device folded in half, or you may put wedges or pillows under the patient's spine. There's problems with these approaches. We're trying to achieve dense contrast layering evenly in the dependent thecal sac. If that contrast moves too quickly and overshoots, we lose our sort of diagnostic ability in the spine, and the patient gets a very bad headache as that dye moves into the head. If the patient is very large or they have scoliosis, you may have insufficient cephalad extension of your contrast, and you could have an entire portion of your spine which is non-diagnostic. Here's an example of a patient who had insufficient hip elevation for a prone dynamic CTM, and you see that contrast just pooling in the lumbar lordosis. Anybody who's performed these exams knows how frustrating this can be when you perform this, and then you have to reposition the patient. The contrast dye moves before you can image right away, and you sort of lost that beautiful sensitivity of the exam. And we became so frustrated with building pillow forts and wedges on our table that we built a device to sort of accommodate this and add that tilt table functionality to our CT table to precisely control the angle of the patient's spine in either the prone or decubitus positioning to really just get that variable out of the way for our patients. And we recently published that technical report describing that device here. Okay, so you've looked at the spine, you see that there may or may not be a fluid collection. The next thing to do is to characterize whether that collection is predominantly ventral or dorsolateral. And that's very important because it will dictate the type of leak that we're looking for. If that collection is predominantly ventral, we'll be looking for a ventral dural defect. If it's predominantly dorsal or dorsolateral, we'll be looking for a ruptured nerve root sleeve or meningeal diverticulum. And if we suspect that it's ventral, we're going to position the patient prone. We're going to inject contrast in the subarachnoid space and immediately begin whole spine CT. We'll acquire a non-contrast CT of the spine or use dual energy to look for any associated culprit calcification or osteophytes. And getting that really early image is so important. Here's an example of that. So this is the immediate scan after contrast injection. We see beautiful extravasation of contrast into the ventral epidural space. Just 30 seconds later on the immediate subsequent delayed image, that contrast begins diffusing. It starts with that, this test wants to turn into a conventional CTM, and we lose that precise localization of where that extravasation is. And I don't know about you, but if this was me or my family member, I'd want to be able to tell the surgeon where to go based on this image, not based on this one alone with any sort of guesswork. And indeed, we were able to tell the surgeon this. In this case, to very nicely through a posterior durotomy, a minimally invasive approach, expose this ventral dural defect for primary repair. It's also important because we can direct our percutaneous therapies in a targeted fashion. This 35-year-old gentleman presented to us with SIH. He had 2 prior non-targeted dorsal blood patches. He had a large ventral epidural fluid collection, and our dynamic CTM demonstrated a ventral defect at T12. We were able to use a very long needle and target that space specifically in the ventral epidural space to put a targeted blood and fibrin patch layering all along the ventral epidural space. This resulted in a resolution of his fluid collection. Honestly, this is a minority of our patients. Most of these are going to need surgical repair, but we do try if we can do so safely. If they can avoid surgery, then that's fantastic. So if the collection is dorsal or dorsolateral, we are going to have a very similar technique, but we're going to position the patient to cubitus. We're going to, again, inject contrast and immediately begin whole spine CT, looking for that area of extravasation from the lateral thecal sac. And if we choose the wrong side, we're going to roll them over quickly and immediately rescan. And we may have to bring them back for a second dedicated scan. Here's one such case. This 34-year-old woman was doing a spin Peloton class. She just changed position on her bike and then all of a sudden developed a severe orthostatic headache. She has this predominantly dorsal and dorsolateral fluid collection, classic findings of SIH in her brain, and we were able to demonstrate a lateral dural defect at T11, 12. You could see by the time that we repositioned her getting ready for in a delayed fashion, you see that it's starting to become a sort of a regular myelogram, and we would have no idea where this leakage was coming from if it were not for that early image. Because of that precise localization, we could target a fibrin glue patch right to that defect. This resulted in a very nice resolution of both her imaging findings and her symptoms. Just a reminder here that this disease is not limited to adults. This 14-year-old boy came to us after developing a severe orthostatic headache after swinging a golf club. This scares me because I love golf, so I think about this now whenever I'm out on the course, but he had a predominantly dorsal epidural fluid collection and a very large lateral epidural defect. We attempted to patch this one as well, but he needed surgical repair. I want to make a small plug here for the value of intrathecal gadolinium. Not all places use this, but people wonder, what if I have a slow leak? What if it's not a fast leak where fluid is pouring out? And we do find these in certain cases. So if I find myself bringing a patient back for a second exam, or we find ourselves scratching our heads wondering if potentially there's something that we're missing on conventional myelography, we inject just 0.1 cc's of gadolinium intrathecally during our CTM. You can see here, this patient had no definite epidural collection on their MRI. The CTM showed no definite leakage out of this cyst, but as we scroll laterally on this MR myelography, on this T1 weighted fat saturated image, we see contrast weeping along here along the intercostal space, allowing us to target this patient for patching, and they had very nice resolution of symptoms after this targeted patch. Okay, moving along to our CSF venous fistula. So here's an example of a humongous CSF venous fistula in the mid-lumbar spine draining into an iliac vein here. This is, again, patients with clinical or imaging features of SIH, but no definite epidural CSF. Here's another example of one of these. I think that classically we imagine these as this hyperdense paraspinal vein. That's sort of one of the first descriptions of them, but they can take many different shapes. They can come in many different forms. This is one of this sort of tangle here around the axilla of the nerve root and along the meningeal diverticulum. You can see this sort of anatomy here laid on this 3D image. This is an image of that same fistula just laid out intraoperatively. Red is showing us the nerve root, yellow is pointing to the thecal sac, and blue is a very enlarged draining vein here at the axilla of that nerve root. These were first identified in 2013 at Cedars and were published in the following year in a case report in 2014 in Neurology. At Cedars, they discovered these by performing rapid imaging following injection under DSM, first in a prone position, but it was very shortly thereafter realized that putting patients on their side resulted in a much increased yield of finding these fistulas. They were using general anesthesia with a breath hold technique, and because of DSM's limitations with the digital subtraction, if the first side was negative, the first side down you chose, they would repeat it on the other side. Very shortly thereafter, this was described by authors at Duke that you could perform this under fluoroscopy, live fluoroscopy without subtraction. The benefits of this, that you don't need to use general anesthesia, you can have more than one field of view, but there's a lot of superimposition under artifacts with fluoroscopy. So this begs the question of why did it take until 2013 for us to be able to see these CSF venous fistulas? Well, the first thing is the positioning, of course. Laying somebody on their side allows for dense contrast to layer in those meningeal diverticula. It's also facilitating gravity to help us with the pressure gradient from the CSF to the venous compartment. We've also learned that inspiration is incredibly important for increasing conspicuity of the CSF venous fistula. And then, of course, well, this is a little bit controversial, but we believe that temporal resolution is important here. These fistulas can be fleeting and multiple phases can help. I'll show some examples of that. A paper out of Duke in 2020 showed us that inspiration increases conspicuity of CSF venous fistulas, and resisted inspiration was demonstrated in this paper out of UCSF to both decrease venous pressure and increase CSF pressure. And this is our goal, is to facilitate the gradient between the subarachnoid compartment and the surrounding venous pressures. I mentioned that multiple phases increases our temporal resolution. Here are 3 CSF venous fistulas which were present only on the very first immediately acquired phase of imaging, and then on the immediately acquired delayed image are completely dissipated. And here's an example of a patient whose fistula was not evident on the first phase of imaging and only became evident on the delayed phase. So we do advocate for at least 2 phases of imaging. There is a trade-off of more radiation, but we do think that at times these fistulas can be fleeting, and if you don't time it just perfectly, you may be missing the fistula. It's important to remember that incomplete filling of these meningeal diverticula can often be mistaken for a fistula. Here's this linear density here in the foramen. It's nice to compare this to your 3D T2 fat saturated image. We can see this boot-shaped meningeal diverticulum with contrast layering within this portion, whereas this patient with his bilobed meningeal diverticulum has this linear density here, which does not correspond to anything on our 3D T2 fat saturated image. And this is indeed a fistula, where this is just a diverticulum. So how do we perform this for CSF venous fistulas? We access the thecal sac. We measure opening pressure, not for a diagnostic reason, but actually in order to augment pressure safely with sterile saline. We do so in 5 cc aliquots until the pressure reaches around 25 to 30 centimeters of water. We then elevate the hips using 2 to 3 pillows at least under the head to prevent contrast from rushing into the head as much as possible. We infuse 5 to 10 cc's of contrast, and then to perform 2 full-length scans in succession, during which we perform resisted inspiration through a 1 cc syringe. We infuse the remainder of contrast, flip, and rescan. Now, we mentioned that you need a second day of imaging during DSM. Do we need one during dynamic CTM? Well, actually, no, not necessarily. You can perform both sides of imaging on the same day with 2 separate injections, or you can flip the patient over and just scan them immediately and sometimes catch these fistulas that way, like such as these 2 fistulas that we were able to identify without re-injecting the patient. But sometimes you don't get so lucky. So this patient we flipped over, didn't see anything, but we had high suspicion. We re-injected, and we see this fistula show itself, which was otherwise very shy. You may also have to repeat these images if you have high suspicion. This was, I thought, a very good exam with dense contrast, but we repeated it a second time because we just thought the fistula was there based on the MRI brain. And we found it, even though the first exam was negative, at the same spot that was previously negative. This patient had an onyx embolization of their CSF venous fistula on the left, had persistent symptoms, and so we thought perhaps she had developed a new fistula, and indeed, contralaterally at the level below, there was a new tiny draining vein. And so these things can reoccur after treatment. You have to listen to the patient. If they're telling you, I'm still having orthostatic symptoms, they could still be leaking, and you must rule that out before thinking of another cause. I mentioned that these fistulas are not always so obvious. It's not always a hyperdense paraspinal vein. This tiny fistula right here in the lateral epidural gutter draining into the venous plexus was just so subtle and could be easily missed. But when clipped, you could see dramatic resolution in the brain findings here. So remember to scrutinize those lateral epidural gutters when looking for these fistulas. It's not always a big, juicy paraspinal vein. In terms of treatment, there's 3 main treatments. Fibrin occlusion, which is our sort of first-line choice for all of our patients. We can perform it the same day as the dynamic CTM. We've published multi-site data on this. We can cure about 59% of them this way, but we think that needle placement really matters. Onyx embolization is a very exciting and promising technique, which has a very high cure rate, but there's less multi-site data on that, so we're still waiting to see how that performs across multiple institutions. And then, of course, surgical ligation, which has a very, very high cure rate, but of course is the most invasive and may require nerve root ligation. I mentioned that we perform fibrin occlusion, and one of the reasons I think people might fail at treating these is that they perform a traditional transforaminal approach when they inject their fibrin. So a traditional transforaminal approach might be approached, when you're trying to do a nerve block, for example, the doctor might put the needle like this in the foramen, kind of layering it along the posterior aspect of the foramen posterior to the meningeal diverticulum. Whereas when we're treating a CSF venous fistula, we're trying to approach the nidus of the fistula and even build sort of this fibrin glue wall along where that draining vein is. So if we do a traditional approach, we're going to get our glue spread in the dorsal epidural space, but that's not where the fistula is. The fistula is arising from the meningeal diverticulum and draining paraspinally. And by putting our needle at the nidus of the fistula in the paraspinal space, we're trying to achieve a glue spread that is along that paraspinal space. In our study, we found that when you have spread that is concordant to the drainage pattern as shown here, then you will have a much greater chance of success of treating the patient's symptoms and imaging findings. So when the glue is spreading along where the fistula is, that is a good thing. When the glue is spreading in the dorsal epidural space, not where the fistula is draining, that is not good. You may want to put a second needle in there and try to treat it that way. People always love to talk about their diagnostic and treatment algorithms and show you this. In fact, the title of my talk is the algorithmic approach. But really, every patient is so different. And each patient has to be approached in a different way. In general, we want to get a brain MRI and a total spine MRI, characterize whether or not the patient has fluid on the spine MRI. If there is fluid, is it dorsal? Is it dorsal and ventral? If there's no findings on the spine MRI, perhaps they have a fistula and work them up that way. But we need to take a more personalized approach to this. And I'm going to make the argument that as radiologists, we need to rethink our role in the context of this disease and step up for these patients, because we are the ones that may be the first to suggest this disease or find the leak, and we have the ability to treat the leak. And so, if you have the procedural skills to do so, I really advocate that you get out of the reading room and step up for these patients, because we can do so much to change their lives. The traditional radiologist proceduralist model does not work for CSF leaks. The way that we just come in and do a biopsy, or the ways that we've sort of learned in our training, because by the time the patient arrives for procedure, it's very possible they've been misdiagnosed elsewhere. Their trust in the healthcare system is low. Their understanding of their diagnostic and treatment options is not at their fullest. And their fear and skepticism of what's going on is high. And these are all setups for failure, not success. And by the time you arrive for the procedure, you may not totally understand what the patient's symptoms are. You may not have optimized their first-line non-invasive imaging with your particular knowledge and expertise of the protocols available at your institution. And there may not be a good infrastructure for follow-up. I just want to remind you that Hippocrates said that it's far more important to know what person the disease has than what disease the person has. And I think that's especially true here. As important as it is to make this diagnosis, we have to get to know our patients. Here at CU, when a patient gets referred to us, we get all of their prior imaging tests and procedures sent to us. We insist on an MRI brain and total spine. And then we start with a clinic visit. We obtain a complete medical history starting from the very beginning. We go over the imaging together. We explain the diagnostic tests and the risks and benefits, as well as the treatment options, and obtain validated health metrics, both for research purposes and as baselines for going forward to evaluate after in the post-treatment setting. I think that our multidisciplinary conference is very important. I would encourage you to do this at your institution, getting together with your neurology and neurosurgery colleagues in a similar way we do so for tumor board for our cancer patients. For all of our patients without straightforward clinical imaging presentations, figuring out what is the best sort of consensus recommendation, and then document that in the patient's chart, thinking about this in more than one way. We could break these patients down into sort of high burn scores, classic sort of patients. We're going to generally perform myelography in these patients to find their leak. We're going to offer them a treatment that's based on their leak type, but it's going to be a shared decision-making process. And if there's any sort of possibility for surgery, I like the surgeons to talk to them about what that option would really look like. If there's intermediate probability, but there's no fluid on their spine, we're going to look for a fistula. And if we don't find a fistula, we're going to treat soft targets, meaning osteophytes that may not be showing evidence of leaking at the time, or cysts that may not be showing evidence of leaking at the time. But perhaps if we patch them, we could offer them some symptomatic relief. And if there's a low burn score, there's no fluid on the spine, we could talk about myelography versus empiric patching, remembering that there's probably a low yield of myelography. But if it's important to the patient, and then it's something to offer. But remember, the age of the patient, it's a lot of radiation exposure. If the patient has connective tissue disease, we are going to be puncturing their dura, and it's not something we take lightly. We follow up our patients at 1 week and 1 month post-intervention at minimum, and we'll repeat the imaging if their pre-imaging was abnormal. And think about next steps. How are they feeling? I want to see their imaging better and them feeling better, both of those things. And then think about next steps from there. Finally, I want to conclude on just one thing, on this question of, is it worth patching the imaging negative patient? I have been lucky enough to be involved in this very important research study, which has currently been submitted and is under review, under peer review right now, of the Stanford Leak program. Dr. Ian Carroll, between 2016 and 2018, started patching people whether or not they were ICHD3 positive for SIH, based on suspicious symptoms for a leak, including but not limited to an orthostatic headache. He had 85 people who completed a series of validated health metrics pre-patch, immediately following their first patch, and then delayed following their last patch. He had 69 people that did not conform to ICHD3 criteria, and 16 of which who did. They underwent an average of 3.6 epidural patches. And these patients had significant clinical improvement. And they had improvement across various domains of health-related metrics. And these domains were clinically significant as defined by the NIH across these validated health metric scores. 81% of these patients had a clinically meaningful response rate. Most of the patients who were ICHD3 positive did, 13 out of those 16. And over half of the patients who were ICHD3 negative did as well. So although it was a much lower percentage, it was still a very large proportion of the patients who are ICHD3 negative. And if we looked at specific metrics of those patients pre their first patch related to the orthostatic character of their headache, specifically how good did their headache get if they laid flat? How much relief could they experience after laying flat for 1 hour? And how good did they feel after laying flat overnight? Those patients specifically, these two categories, were the most predictive of having clinically meaningful improvement over long-term follow-up for symptomatic relief. The fact that there is this pattern in the patients who respond related to the orthostatic character, combined with the fact that these improvements were sustained and increased over several rounds of patching, argues against a placebo effect in this patient population. Here's this sort of graphed out in longitudinal form. The patients who had the most relief in their pre-patch headache severity after laying flat for 1 hour had the most improvement in their global health metrics. So I just want to conclude by saying it could be incredibly frustrating and feeling like you're beating your head against a wall sometimes, patching things you can't see. But these patients need us. And if there's something you could do for these patients to make them feel better by taking some of their own blood and moving it to their epidural space, there's so many things that are much more harmful for these patients that they may elect to go through: drugs, surgeries, other therapies, because they are suffering so much. And if you have the technical skills to offer your patient potential symptomatic relief and life-changing, clinically meaningful improvement, I suggest taking a thorough history and offering them that treatment. Thank you very much. And I'd be happy to answer any questions you have. I knew I ran a little bit over, but I'm happy to stay a little bit longer for any relevant questions.
Well, thank you, Dr. Callan. This was an excellent and inspiring presentation. We do have a couple of minutes for some questions. I'm opening the Q&A here. I think one of the first questions that showed up is, will a blood patch work if your iatrogenic leak has been left for 5 months without any intervention? What's your opinion about that?
So it's very hard to say. Thank you for the question. I think that we should always try. It's, again, in skilled hands, an image-guided blood patch is very safe. The downsides are very few. I think that you should give it a shot. If you can at all find something that localizes where that might be, if there's a bleb, if there's some edema, in the dorsal epidural space that might give you a better sense of where to target that patch, that's very good. And potentially even give a site for surgical localization, that's even better. It's absolutely worth a try, and it's worth a try more than once. If the first patch doesn't work, but you had a puncture, then you should absolutely try again. And you should have your imaging optimized with an MRI protocol that may give you a subtle clue to where that leak might be. And if all else fails, and really, an expert who's interviewed you and looked at your case thinks that this is what is being caused, a neurosurgeon may elect to look at the dura in that spot. This is controversial, but depending on the surgeon, of where that puncture was, to see if there is a dural defect at that level, depending on your case. So I would say absolutely a blood patch is appropriate in that setting.
And to continue about the risks of potential blood patch, as you alluded to in one of your last slides, like to perform like epidural blood patches in patients for whom the evidence is, or the imaging is negative. What, in your opinion, would be the potential risks of performing like a high volume blood patch in somebody who is not actually leaking? Are there any concerns about that?
Yeah, so when we consent our patients or talk about the procedure, of course, every procedure has risks. There's always risks of bleeding and infection in every procedure. There's also a risk that that blood gets into the subarachnoid space in the CSF and causes arachnoiditis. And we think this risk is very, very low, especially with image-guided patching, but is a potential risk. There's often pain at the site of the patch, soreness in your back. We ask you to lay flat for a period of time after the patch. So if you have hypercoagulability, for example, you could develop blood clots in your legs. But these are unusual. The vast majority of patients do not have this. Knock on wood, but we have had no very serious complication from giving a patient a blood patch. the higher volumes you go, and if you move up in the spine, up and towards the cervical region, of course, you worry about cord compression or injury of the cord. But again, in skilled hands with imaging guidance, those are really the main risks we think about.
Thank you. Another question was asked, what is the reason for normalization of the brain findings over a period of time in SIH patients?
That's a great question, and one that we don't totally know the answer to. I mean, you could imagine mechanistically that as the leakage continues, perhaps the CSF production increases to compensate for this, and so those imaging findings, the venous engorgement gets sort of pushed by that increased pressure. Many of our patients with long-standing leaks, when you measure the pressure could be even high. So is that perhaps a result of that increased CSF production? We don't totally know. We also know that as the dural defects occur and the CSF is leaking into the epidural space, membranes form in the epidural space that can put back pressure into the CSF compartment that perhaps also contributes. But these things do not result in symptomatic improvement for our patients or complete symptomatic resolution, but can result in that normalization of the imaging findings over time.
Great, thank you. I think this is a question about a colleague radiologist here. I think it's Dr. Kawaki asked, you have patched a patient with a bleb despite documented leaking into the dural space. Were you not afraid of blood from your blood patch leaking into the dura and causing arachnoiditis? He has seen one tragic case where it happened.
Yeah, absolutely. So a couple things. One, I absolutely was. And when that occurred, first of all, we consent to all of our patients for this. And before we attempted to patch at that level, we had a long informed discussion with the patient about that as a potential. We also, in that case, did not use blood. It was only glue. In our experience, we have not seen as much or any true arachnoiditis from the fibrin glue injection. In that case, it was about 2 cc's of glue in the epidural space along the bleb. Also, the tissial fibrin glue really solidifies very, very quickly in the epidural space. So, within a matter of seconds. So, doesn't have the same sort of viscosity of blood to sort of slowly get into the subarachnoid compartment as when we get our glue into the epidural compartment. But it's a good question, and it's absolutely something to think about.
Mm-hmm. And I think this is from the same person, a more technical question. Where do you stand while performing a CTM? Do you have a very long tubing or stand behind gantry?
Yeah, so with my fistulas, I inject and then run into the control room, literally run into the control room, wearing lead, of course. With the ultra-fast CTM, when there's dural defects, I use very long tubing and I stand in the shielded portion of the CT scan. Our scanner has there's one portion right behind the control panel, where there's less radiation, of course, also wearing lead. It's so important to get that fast timing that I'm in the room as the injection is occurring, because if I were to inject and then run into the room, it would be too late. So I actually have the tech start the scan. I hear the machine start, the patient starts moving, and then I start injecting as that's happening, because I just don't want to miss that early image. It's literally the difference between the surgeon going in and not finding the leak or finding it.
Okay, thank you. What are your thoughts on the cases of individuals who fluctuate between hypotension and hypertension? Is it dural compliance issue? And what do you suggest in terms of approach?
Yeah, it's an incredibly difficult question. We know that there's a phenomenon that's sort of termed popping the balloon, so to speak, the patient who is in high pressure who subsequently develops a CSF leak. There's also patients who themselves feel a sense, today I'm in high pressure, today I'm in low pressure. I don't know if it's exactly that's what it is that they are in high or low pressure. It certainly is what they're experiencing. We certainly have a lot of work to do to reconcile these things, to know exactly, is it that they're feeling in high pressure, or is it perhaps epidural venous hypertension or changes in venous dynamics that we are not characterizing or measuring appropriately? There's a lot more work to be done in that space, but many patients come to me that we see in clinic who this is the question. Some days, the clinical phenotype is more in keeping with hypertension. Some days it's more with hypotension. It's a combination of what are their symptoms, what does the imaging look like, does it point us in one direction or another, and then go from there. Is it worth trying myelography and concurrently measuring pressure? If it's extremely high and the imaging looks like hypertension, then we can start looking in that way. Should we start with a fundoscopic exam to look for evidence of optic nerve abnormalities or optic disc abnormalities to suggest papilledema? You really have to be holistic and really involve all of your colleagues in a multidisciplinary fashion.
Mhm. Thank you. Another question here is in regards to a chronic a rebound intracranial hypertension. If you have any advice on how to deal with patients who have long-term symptoms of that.
Yeah, that's a great question. I think that we underestimate how chronic and debilitating this can be. I think that patients who live with leak, particularly in my experience, patients who live with leaks for a very long time and then are treated, can have a very long protracted recovery, which often involves long-term management of rebound intracranial hypertension. And this is part of the reason that I feel it's very important for us to follow these patients long-term after the fact. There's a number of medications which we prescribe, acetazolamide, methazolamide, topiramate, even down to just diuretics like spironolactone or furosemide. And it's easy to say, oh, these are easy. Just take some Diamox, you'll be fine. It turns out that these medications are not easy to take. There's a lot of side effects. Patients can be miserable on them. So you really have to work with your patient to starting at a low dose and titrating it to a place where they feel like they're getting symptomatic improvement, but are not having intolerable side effects. And that's what I would say. It's really an individual patient based on other health issues that may be going on in terms of choosing a medication, perhaps some lifestyle modifications, and then just working with your patient in that way.
Thank you. But I agree. I think longitudinal follow-up is paramount in SIH patients, as it is an ongoing disease. We have lots of very interesting questions left. I'm afraid we will not be able to answer all of them, but we will try to reach out and set something up in terms of and provide some answers. Maybe two more questions. We have somebody asking here if you could speak to the promising improvement in granularity and sensitivity of photon counting CT imaging to see subtle CSF leaks, especially at cysts, bleps, and VFs.
Yeah, absolutely. So the two principal benefits of photon counting CT over conventional CT is number one, the decreased radiation dose, substantially decreased radiation dose. This is important in CTM because one of the downsides in CTM compared to DSM is that there's more radiation. So taking that away, no matter how much you can reduce it, and it's substantial in photon counting CT, is important. Then second, and perhaps the most important reason that photon counting CT is a very powerful tool is the improved spatial resolution. So in typical CT, we get slices that are 0.6 millimeters thin, and in photon counting CT, you can get ultra high resolution 0.2 millimeter thin slices. So you could imagine that there are tiny CSF venous fistulas, like some of the examples I showed you, that are simply below the resolution of a conventional CTM, and that would only be diagnosed with photon counting CT. So this is a very important tool, and where I think the field is heading is the use of this technology in conjunction with these other techniques and provocative maneuvers. And I think that a lot of patients wonder, should I wait to try to get just that? Or I think that there's a combination of things that go into these decisions. But certainly, if you've had conventional workup, which has been negative at a place that knows what they're doing, that looking to try to get to a photon counting CT might be a reasonable next step.
Mm-hmm. Thank you. And one more question. In your experience, is there a difference between rates of rebound hypertension when you compare treatments like fibrin glue versus transvenous embolization or surgical ligation?
It's a great question. I think there is so much we don't understand about rebound hypertension that just doesn't make sense to me at all. Let me give you an example. We have patients who get surgery, and intraoperatively, there's lots of CSF lost, and the surgeon makes a primary repair of the dura. The patient wakes up in the recovery room and within an hour has rebound hypertension. That makes no sense if your theory is that it's CSF production over production and compensation. It makes no sense, right? So there's something that we're not understanding about this hypertension phenomenon. We used to sort of say anecdotally, oh, if you get hypertension, that's a really good sign. That means that the leak was absolutely definitely treated. Several studies have shown now that that's not necessarily the case, including some of our own work. One very interesting paper came out of Cedars looking at morphology of the transverse venous sinuses in the head as a predictor of rebound intracranial hypertension, showing that if you had areas of narrowing or stenosis or even congenital hypoplasia of the transverse sinuses, this was a predictor of rebound intracranial hypertension. I'll just say, I know it's not a satisfying answer, but we just don't know enough about this phenomenon. It is a real phenomenon, but these sort of analogies we give to patients about fluid production, and I always tell them, okay, it's like we're plugging the hole in the sink and the faucet's still running. These are probably not accurate. But it's good ways of thinking about it. It does seem to follow a pattern after patching or surgical repair, but there's still so much work that we need to do.
I agree. It's well, we still have work to do, but I think you're a wonderful, excellent example and leading the way for many of us here in Canada and in the States as well. Thank you so very much for your time today. Your presentation was excellent. I think we would be able to go on for 2 more hours, but we have to stop at some point. Some more excellent questions in the chat box. I will see with the organization of Spinal Canada whether we can answer those under the name of Spinal CSF League Canada. I would like to thank everybody for joining today. It was again a wonderful evening, and we'll see each other soon. Thank you again.
Thank you so much. Good night, everyone.